Request start.
Okay. Shall I move on with the slides?
Yes, sir.
Okay, fine. Okay. So good evening, everyone. Welcome to the December 20th December program of Indian Thyroid Society, the Thyroid Clinics. So we have two interesting cases and a quiz this evening. Just a few words about Indian Thyroid Society before we go on to the actual program. An organization established in 2003. I'm currently the secretary of Indian Thyroid Society, so that's my role here. Currently, Dr. Shashank Joshi is the president. So we established in 2003, involves endocrinologists, endocrine surgeons, nuclear physicians, general physicians, all of them can be members. So all modern medicine doctors can be members of this and are. ITS is a member of the IOTA, which is a Asia Oceania Thyroid Association, and has got about 2,000 members at present. The founder president, Professor R. Vijay Kumar, has been instrumental in getting the organization to this level over the last 20 years. And the current president, as I said earlier, is Dr. Shashank Joshi. Past president, Professor Sarita Bajaj, has been the main force behind having these academic programs being run at a very regular interval every month. And Dr. Miniji Pillai is the current server. The scientific committee has Himagiri Rao, who is the current vice president, Pramila Kaldra, Sujay Ghosh, who is the current joint secretary, Dr. P.K. Jabbar, Dr. Krishna Sheshadri, Dr. Mohammed Riaz, Dr. Sushil Gupta, Dr. Ashraf Ghani, Dr. Mohan Shanai, and Dr. Ameya Joshi. The aim of the organization is really to make sure that we help the endocrine as well as the general medical community discuss about thyroid and have academic activities in the area of thyroidology. We also look to promote public education awareness. We have a flagship journal called the Thyroid Research and Practice, which is published twice a year. And we award fellowships of the society, and we encourage everyone to be part of the society as members. The ongoing activities over the last 2 years has been structured. We have CMEs, updates, symposias, and we 6 months ago conducted our ITS Con in Cochin, and the next ITS Con is going to be in 2024 in Lucknow. The weekly programs, which now has been actually made monthly, involves journal club, case conversations, monologue or duologue, panel discussions, meet the professor, quiz, workshop, and CPC. All this has been received with significant interest by our endocrine as well as general medical community. We celebrate the Thyroid Awareness Week in May, the World Thyroid Day on May 25th, and Thyroid Awareness Month is actually celebrated in January. So that is next month. Every year, this is celebrated. We do give annual grants, both for postgraduates as well as for the faculty. So please visit the website for details of this research grants, which again is due to be announced very soon in the next week or so. The Thyroid Clinic Research and Practice, as I said, is published twice a year. Even electronic copies are available, and it's free to the members. The fellowship was awarded for the first time last year during the ITS Con, and people who are eligible would be offered or conferred the fellowship of Indian Thyroid Society. For details of the eligibility, please again look at the website or contact one of the officials who will be able to give you that. The textbook, ITS textbook of thyroid disorders, was again published during the ITS Con in May 2023. and the editors were Dr. Sarita Bajaj and Dr. Rajesh Rajput. There have been consensus guidelines that have been published. The thyroid disorders in pregnancy consensus statement was published in Thyroid Research and Practice in 2023. The upcoming guidelines include the management of subclinical hypothyroidism, which is awaiting publication, and already the management of thyroid nodules has also been drafted and is awaiting publication. So previously, there have been other guidelines that have been published: dyslipidemia and thyroid dysfunction, hypothyroidism, diabetes, depression, and thyroid dysfunction. All this has been over the last decade or so. And this is a website. Please do visit the website where you can actually join as a member. Membership it's a lifetime membership, and the details are on the website. Also, all details and all recordings of the academic activities are available on the website. These are the details of the membership, and again, that's there in the website. So please access the website for these details. Thank you. So I think we can move on to our program. It's 8:01. So let me first welcome Dr. Preeti Rao, who is currently the professor, and she's in Department of Endocrinology, SGPGI in Lucknow. All of you know her very well. She's a very experienced endocrinologist whom we have all listened to over the years. And is a very good speaker and a teacher. She has quite a lot of publications in peer-reviewed journals and written more than 20 text chapters. Her areas of interest are PCOS, type 1 diabetes, and gestational diabetes. She has held the position of member of task force for international evidence-based guidelines for PCOS management. Welcome, ma'am. You're not. I don't think you're audible.
Can you hear me now, Arun?
Yes. Yes.
Yeah.
Like
actually, my
wonderful.
computer audio is not good, so I'm using my phone's audio. So you will see two people joining as Preeti. Okay.
That's fine.
I'm sorry
that's
about
fine.
that.
But
Yeah.
the voice, it's loud and clear. So it's
Okay.
Thank you.
So should
So
we?
do you want to introduce Dr. Anirban
Yeah.
Sinha? Please,
Yes. It's my pleasure to introduce Dr. Anirban Sinha, who's the moderator for today's thyroid clinics. Currently, he holds the Professor of Associate Professor Endocrinology, Medical College, Kolkata, and has other clinical affiliates as visiting endocrinologist at AMRI Hospital. He's chairman of the Ethics Committee for Central Hospital SCR and has achieved quite a lot in his career, receiving the A.V. Gandhi Gold Medal for Excellence in Endocrinology in 2010 and the Young Thyroidology Rising Star of 2014 in the 11th Congress of Asia Oceanica Thyroid Association. He's fellow of the American College of Endocrinology, and I think it looks like editorial committee or of the Endocrinology and Metabolic Research, the ACTA Scientific Gastrointestinal Disorders and Hormone Research International Journal. So it's a pleasure to have you, Anirban, on this thyroid clinic.
Thank you, madam. Thank you for your kind introduction. And I thank the organizers for inviting me for this interesting case discussion. This is a very good initiative of the Indian Thyroid Society to start having this kind of interactive sessions with the clinical cases that makes us more aware of the clinical oriented case discussion and the orientation of the academics based on the clinical cases. That is very important as we see patients day-to-day practice. So we have two interesting cases today to discuss. First case is congenital hypothyroidism, an approach to the newborn. This is done by Dr. Archana K, Senior Resident, Department of Endocrinology, SGPGI, Lucknow. she is going to present this interesting case, and maybe along with that, she also discussed the approach of the newborn screening as well, because we know that with the starting of the newborn screening, there is a very good case detection rate throughout the world, and there are some difference in the guidelines still regarding the who to be screened or not to be screened, or whether universal screening is recommended. So on that, she is going to highlight. So over to Dr. Archana talk on congenital hypothyroidism and case-based approach. Archana, please.
Thank you, sir. Good evening, everyone. So the first case for today evening is Miss A, a 18-month-old female who presented to us at 18 months with history of poor height gain, noticed since 6 months of age, and associated features were dryness of skin, constipation. She used to pass stools once in 3 days, and she was very irritable with hoarse cry, and all the symptoms had begun by 6 months of age. And also she had developmental delay, which was global. She had no history of increased sleepiness, fetal edema, feeding difficulties, choking, or lethargy. No, there was history of cold extremities. There was no neck swelling noticed by the parents. No history of apparent hearing or vision abnormalities. The dentition was delayed. There was no history to suggest chronic kidney disease, chronic liver disease, or congenital heart disease. No history to suggest malabsorption, blood transfusion, polyuria, polydipsia, bony deformity. There was no history of any head trauma or brain injury. No headache, seizures, or fever. No history to suggest other hormone insufficiency like hypopituitarism. On treatment history, she was receiving calcium and vitamin D supplementation for the poor height gain. In the birth history, she was a full term, normal, delivered through vaginal delivery. She cried immediately after birth. She weighed 3.1 kg. There was no history of ICU stay or neonatal encephalopathy, sepsis, seizures, prolonged neonatal jaundice, or neonatal hypoglycemia. In the developmental history, her gross motor development was head holding by 1 year of age, and till she presented, she had no rollover, and fine motor was unidextrous reach, and in language, she had just cooing, and in the social aspect, she had only stranger anxiety. So developmental age corresponded to 3 to 5 months. She was immunized for age, and in the diet history, she had a poor complementary feeding with mainly milk-based diet. And in the family history, there was no history to suggest hypothyroidism in any of the first or second degree relatives. So on examination, she was an irritable child. Her vitals were stable. There was pallor noted. Her AF was 3.4 centimeter, 3 into 4 centimeters, and posterior frontal nail was also open. She had a depressed nasal bridge. There was telecanthus. She had open mouth with protruding tongue. She had mottled coarse skin over the thorax, cool extremities. She was very irritable and had hoarse cry. There was no tooth eruption. There was frontal bossing, and she had a normal female external genitalia. She weighed 7.4 kg and stood at minus 2.75 standard deviation, and length of 70 centimeters at minus 3.69 Z scores, with a head circumference of 44 centimeters at minus 1.62 Z scores, indicating a chronic malnutrition. Her upper to lower segment ratio was 1.6. Systemic examination was grossly normal, except that she had umbilical hernia and there was hypotonia. However, the reflexes were elicitable and there was no delayed response. So in the database, we have an 18-month-old girl born out of non-consanguineous marriage with developmental delay, with complaints of poor height and weight gain, constipation, dry skin, hoarseness of voice, and irritability. And she had all features to suggest hypothyroidism in the form of open mouth with protruding tongue, mottled coarse skin, cool extremities, hoarse cry, delayed dentition, and frontal bossing. So our clinical diagnosis was global developmental delay, probably hypothyroidism with anemia. So in the differentials, we had kept most probably the cause must be congenital, because onset of symptoms was at 6 months of age. And so among that, most common would be thyroid dysgenesis, contributing to 80 to 85% of the cases, followed by thyroid dysharmonogenesis, which contributes to the rest 10 to 15% of the cases. and a lesser possibility of iodine deficiency, and rarely Hashimoto's thyroiditis. So we proceeded with her investigations. She had microcytic hypochromic anemia with a normal LFTs and KFTs. Her TSH level was more than 100 MIU per liter with a low T4 of 5 nanomole per liter. Her bone age was delayed, carpal being 6 months and phalanges being 9 months at the age of 18 months. Her ultrasound thyroid was done and the thyroid gland was not visualized. Due to economic constraints, we couldn't proceed ahead with the nuclear scans. So her final diagnosis was congenital hypothyroidism, probably athyrosis or ectopic thyroid. In short of nuclear scan, we won't be able to definitely tell the diagnosis. So we started her on thyroxine replacement at 10 microgram per kg per day. That was 75 micrograms per day. And we called her for follow-up at 2 weeks and tested for T4, which was 160 nanomoles within range, that is 90 to 192 for her age. And she was continued on the same dose. And following which she came at 1 month with a TSH of 5.7. The upper limit for that age is 5.41 and a normal T4. And hence we continued her on the same dose. So our main focus of discussion today will be the essence of newborn screening, how this child could have been prevented from having all these complications and a better developmental growth and development. So newborn screening for, sorry, till now any doubts?
So maybe you have presented nicely. So what do you want to discuss maybe before going to the screening part, that how do you approach a patient if the patient has congenital, suspected congenital, or at the age of 18 months, it may be anything, honestly. So how to differentiate maybe clinically and by history-wise the thyroid dysgenesis and the iodine deficiency disorders or other drugs which can also affect maybe the maternal history of drugs or any other things which you can think of. How to approach clinically before going to the screening. Maybe we'll discuss later.
Yes, sir. So I'll keep the database on. So her age of presentation was 6 months of age, and from when she developed the developmental delay.
So why do you think that non-consanguineous is important? What are the genes which can potential have a congenital hypothyroid? Maybe can we discuss?
So there are autosomal dominant and recessive genes involved. So the most common is the dysgenesis part, where you can have an autosomal dominant pattern of inheritance, like the NKX 2.1, that is TTF1 gene. And like for recessive, mainly the hormone dysharmonogenesis is mainly inherited in autosomal recessive manner, except for the Duox mutation, which can be dominant as well as recessive. The other one is the TSH receptor defects and TSH beta subunit, that is THR beta subunit defects also can be inherited through family.
Sure. But one thing, how do you differentiate the autosomal dominant versus inheritance as a clinical history you take from the patient? People should know and people should understand that. How do you take the history so that it looks like autosomal dominant or autosomal recessive?
So in the recessive pattern, yes, sir. In the recessive, both the parents can be asymptomatic mostly, and or can have mild forms of the disease. Whereas in dominant pattern, usually there will be a significant family history of siblings or the parent or the first degree relative who can be affected with the disease at the early onset of age.
Maybe the recessive one is the siblings are more maybe get affected. On the other hand, dominant, you all the family history of paternal, maternal, depending on the situation on the different genes, you can get affected. So you have a positive family history more, or the sibling history is more common maybe in the autosomal recessive. Yeah, that is the way of. And also how to differentiate the height gain. Do you want to go for a single height or do you want to look for a height velocity if you can? How to approach that?
Yes, sir. So basically in congenital hypothyroidism, weight for the age and length for age at birth will be normal. So gradually, when they progress, they will have short stature and poor weight gain. So similarly, in this child, it was noted her birth weight was 3.1 kg for a term child. That is normal. So this is one differentiating features. They are not stunted at birth, and we should have a serial height gain to comment the.
Yeah.
And then, if it is a congenital hypothyroid and severe congenital hypothyroid, usually they present in the neonatal age. They will have a stormy neonatal course. That is, they can have a prolonged jaundice, they can have sepsis, they can have hypothermia, and they can have respiratory distress. And even at birth history, they can have a delayed, late for gestation. That is, more than 42 weeks can be the the gestational age for the baby. These are the common things. That prolonged hyperbilirubinemia is one of the strongest indicator for, and we should screen for congenital hypothyroidism. But this child had no stormy course, however.
That's more suggestive of it occurred maybe not at the very beginning. It's at least not a serious hypothyroid at the beginning when the child was dealt. What is the premature child or the term child?
So it was a term child weighing 3.1 kg.
Yeah. So thank you. So how do you decide? Maybe another important point to discuss for the people to understand as well, that how do you decide the treatment part? So why do you take the 10 microgram per kg, and why each age you decide what microgram per kg doses, and how to plan that, and why do you did not increase the dose? That is very important. People should understand as well. So please discuss slightly elaborately on that.
Yes, sir. So when we start, usually in severe congenital hypothyroidism, that is a infant who is presenting less than 1 year, and it is a severe case, we prefer a higher dose, that is around 15 microgram per kg. She was 18 months, and so we thought of starting at 10 microgram per kg. Both less and more is harmful for the child. Both can lead to neurodevelopmental delay. So we should be very careful at choosing the dosage. So immediately we call it 2 weeks. So this is a major indicator, that is T4 will normalize by 2 weeks. So here it was normalized. So hence we continued on the same dose. In the follow-up at 1 month, her TSH was just above the normal. 5.41 is the cutoff for her age. However, the T4 was in the upper range of normal. That is, we tend to maintain in the upper half of normal. So T4 was normal. So that is why we continued on the same dosage without increasing the dose.
Sure. Thank you. And just to mention that, what are the clinical things which can help you to think that the patient is getting overdose? Maybe the excess dose, as you said. So how to see it, maybe in the clinically, the slightly long run, maybe not within 1 month, but after that, if the patient is on and patient lost to follow up, come back to you after 3 months. So what do you look for, maybe? So people can understand without doing the test as well.
Maybe features of hyperthyroidism, like the like excessive sweating, or the child who has tend to lose weight because tend to gain weight with hypothyroidism on treatment, and then again they start losing weight, and the mother can feel the palpitations of the child while breastfeeding if there is excessive heart rate, which the mother can notice.
Thank you. So go on with your screening part. If any other questions from the audience, if we can get the questions from the viewers, if we can have, so we can get that. Can we get for the technical team? Can we get that data, question answers? I don't see any questions from uh, the Zoom meeting room, but
Sir, no
is there
question
any?
has come. Sir, no question has come.
Okay, sure. Then go on to the
Hello.
discussion of newborn screening.
Yes.
Yes, sir. So the newborn screening for congenital hypothyroidism was initiated in 1970s, to be specific in 1963 in Quebec and Pittsburgh. It is the standard of care in most developed countries since 1980 itself. The screening is available at selected districts in India, that too in few states. To top the list are Kerala and Goa currently. So let us look at physiology, how the TSH raise and T4 raise and fall happens after the child is born. So in the cord blood, the level of TSH is 10 to 20. Within 1 hour after birth, the sharp surge to maintain the thyroid, to maintain the thermogenesis basically. So it raises up to 50 to 100 and peaks by 24 hours. After 24, it starts declining and returns to normal by day 3. So this becomes an important part why we screen between 48 to 72 hours. And the T4 and FT4 response is increases by twofold and peaks by day 2. It remains high till 3 weeks, especially the T3 remains high till around 4 weeks, and T4 and FT4 by 3 weeks it starts falling. So here you can see the change. The x-axis represents the day of life, and the y-axis the hormone parameters. This is the newborn at preterm newborn, that is 23 to 27 weeks. This is up to 32 weeks. This is up to 37. This is a term child. So in a term child, this is a normal response. The T4, FT4 peak till day 7, and then they have a fall. Even the TBG raises by hepatic production, and then there is a fall. Similarly, T3 also raises, but it remains elevated till day 25. Wait, day 28. This concept is very important for the screening of newborn. Now coming to RT3, since the D3 levels are high in newborn, so first we can see there is an elevated RT3, and further as the D3 levels come down and D1 increases, there is a fall in RT3. Similarly, TSH starts peaks at 1 hour, and further you can see a fall in the term newborn. Whereas in a preterm, you can see the graphs here. There is a delayed response for T4 as well as the TSH raise. So why TSH testing is important? We have two options. We can either do an FT4 or a T4 based primary screening of thyroid hypothyroidism, or a TSH based screening. So why we choose TSH? So a 10 to 15%, there is a log linear relationship between the TSH and FT4. So with a 10 to 15% decrease in FT4, you can see 100 to 200% increase in TSH. So for an example, if FT4 drops from 1 to 0.5, that is if it is half, the TSH raises 10 times, 100 times, sorry, 0.5 to 50. So, and TSH is done using a immunoassay unit per liter. So why TSH we are preferring? One is the cost is more, and mainly detect even clinical hypothyroid. We tend to miss with T4. However, T4 has other advantages like secondary and tertiary hypothyroidism cannot be detected with TSH alone, and even hypothyroxanemia and babies with the delayed T4 with low T4 but delayed TSH response, like in sick euthyroid babies with neonatal illness is present, then they'll have a delayed response for TSH. They can have false negativity. So when given an option, including FT4 along with TSH is definitely useful. But in a setting, in the setting of our country, TSH will definitely help us screen majority of the newborns. So most common picture what we see is the normal FT4 or FT3 with an elevated TSH, or a low FT4 with an elevated TSH, or in central hypothyroidism where you will have low FT4, FT3 with a normal or a low TSH. So the most common etiologies are, as told, thyroid dysgenesis, agenesis being more common, dysharmonogenesis, where thyroid peroxidase enzyme deficiency being more common, and deox, we have to mention, this is a partially reversible disease. So in this mutation, when you have this mutation, you should ideally reassess the thyroid function test at 3 years of age. There can be causes can be transient, like in iodine excess or deficiency. If there is maternal blocking antibodies, maternal medications like antithyroid drugs, and as explained, prematurity, low birth weight children. Other cause, central hypothyroidism being very rare, and rarest being other causes being thyroid hormone resistance and metabolic defects. So our main focus is on the thyroid screen. So first we take a heel prick or cord TSH levels. So first TSH of more than 220 will define a screen positive for the child. So if it is less than 20 or TSH less than 34 in the sample between 24 to 48 hours, like in some babies who have early discharge and you do within 48 hours, so this is the cutoff, that is less than 34, then it is designated as normal and they are discharged. If then once we see 20, so we have to now check the exact values. If it is more than 80, definitely the child is severe hypothyroid. So you should take the confirmatory sample and not wait for the reports and immediately start on treatment. Sorry, for TSH more than 40, we have to do a confirmatory venous samples with after 72 hours of age. So I'll be coming to this in some time. And between TSH of 20 to 40, you're little safe. Or a TSH value of 34 to 40 in the sample at 24 to 48 hours, you can recall the patient at 7 to 10 days of life. So this will help even for the sick neonates, giving a time period of 7 to 10 days. So you repeat a TSH. And any value of more than 20 at age of less than 2 weeks, or a TSH more than 10 at the age of more than 2 weeks, that means the second test is positive. So you confirm using a venous sample. This is the venous sample, sorry. So coming to these both groups, if there is a normal T4 and a high TSH, then ideally we should repeat a TSH after 2 weeks. And anything less than 10 is always normal. And more than 10, after 3 weeks, even if it's normal T4, this situation is for normal T4, you should ideally start treatment and reassess at 3 years of age. If there is low T4, then there is no doubt we obviously start, but we should be aware of certain values like low FT4 of less than 1.1 nanogram per deciliter or low T4 of less than 80 microgram per deciliter. Irrespective of the TSH, we start the treatment. However, in values like less than 1.17 FT4 and T4 of less than 10 microgram, and then you should consider the TSH criteria, that is more than 20 for less than 2 weeks and more than 10 for more than 2 weeks. We should start treatment. If there is a normal T4 and TSH, then there is no need for treatment. Once we initiate treatment, we should look for the cause. So we shouldn't delay the treatment because you are harming the child, for especially for the neurodevelopmental aspect. So within 7 days of starting treatment, you should image the child, like ideally ultrasound with the Doppler has a better sensitivity to detect an ectopic thyroid, and otherwise if they are affordable and you can do a scintigraphy, technetium 99 bar iodine 123, which is the most preferred. Due to non-availability, technetium is done in most of the centers. So if it's an absent gland, you know it is athyrosis. If it's an ectopic visualization, it's an ectopic thyroid. If it is a small gland, you think of thyroid hypoplasia. And on the thyroid scan, for enlarged gland and normal size, there are various disorders like reduced uptake when there are anti-thyroid drugs. And they usually the thyroid harmonogenesis will have goiter. So that goiter gives us a clue. And reduced uptake in the thyroid and NIS mutation, where there will be absence even in the salivary and gastric mucosa. So it is an absolute whiteout in the nuclear scan. And if there is a normal uptake, then for disharmonogenesis, we do a PERT flow rate. And anything more than 10% radiation is 10% to 90% is moderate, and more than 90% discharge will be of a severe disharmonogenesis. Coming to the summary of screening, we should screen every newborn, be it a low birth weight child, be it a preterm child. So every child will undergo a newborn screen at 48 to 72 hours of age. This is the most important fact. We shouldn't get confused that the peak of TSH is delayed, so we shouldn't do a sample. No, still we can get a low T4 values, and you may have to start children on treatment. So this sample is still important. So, and the screen cutoff to confirm or rule out CH is TSH of more than 20 and more than 80 and confirmatory samples simultaneously. For more than 40 to 80, you take a confirmatory sample after 72 hours, and for 20 to 40, you give a time of 7 to 10 days of age. And anything more than 20 for age less than 2 weeks, and more than 10 for age more than 2 weeks, with a low T4 and FT4 as mentioned before, we confirm the diagnosis and the treatment is started. And after 3 weeks, any TSH more than 10, with even with normal FT4 and T4, you should start on LT4 and reassess at the age of 3 years. So who need rescreening? So rescreening in preterm infants and twin pregnancy is advised at least 4 weeks of age, and if an early discharge is planned, then at least by 2 weeks of age. So we have 3 case scenarios just to brush up what we have learned till now. So this is a term child. So every word here in the case is important. It's a term newborn who underwent NBS using the DBS sample. So DBS gives the whole serum units, and when you multiply by 2.2, you will get a serum units. So this here reported value is always in serum units, that is 35 MIU on day 3 of life. So our first criteria, that is 48 to 72 hours, is met. And now the value, so it is more than 20, so it is 10%. Where does it fall? It falls in the third category, that is TSH between 20 to 40. So what we should ideally do is to recall the patient at 7 to 10 days of life, and then repeat a TSH, and further the chart should be followed. So the next question was, how would you do the etiologic workup? Just for example, if the child turns out to be positive and ultrasound, like in our child, and nuclear scan, but that is in addition. And for treatment, so as already discussed, 10 to 15 microgram per kg per day is started. You give on an empty stomach, and you are not supposed to give iron or calcium along with the medication. In less than 6 months of age, with 5 to 6 ml of breast milk, you crush the tablet because there is no liquid solution available, and you feed the child. For more than 6 months, you can do even with plain water, normal drinking water. So now another example, a newborn for NBS sample is collected from the cord blood sample. So it can either be a cord blood or a heel prick. So it is a cord blood sample. So now we know that age is anyway less than 48 hours, and it is sent to a routine lab. And the report came as 36 MIU per liter. So what is our interpretation of 36? So again, it falls in less than 34 weeks, but less than 48 hours. So we should take this cutoff, that is 34 to 40. Since it is 36, still the screen is anyway positive, and it falls in here, and we have to recall the patient at 7 to 10 days of life. So we have recalled the patient, and now the repeat TSH, for example, is 19. So now we knew that child was a term, and we have called at 10 days. So it is anyway less than 2 weeks, and a TSH of 19. So this becomes negative. So TSH of less than 2 weeks. So we are not supposed to treat this patient. So would you like to further repeat the test? Yes, in some centers, since it is borderline benefit of doubt, we can really repeat the patient. If by chance this was a sick euthyroid patient, or a patient who was or a child who was born preterm or very low birth weight, then ideally we have to repeat at 4 weeks or 2 weeks if there is an early discharge. And really, we should reassess the patients once we have started on LT4. So this topic also has to be touched. We should reassess the patient at 3 years of age. So how do? You have to reduce the dosage by 1/3, and then you should check the TSH at 3 to 4 weeks. And if it is more than 10, that indicates this is a permanent congenital hypothyroidism, and you should continue the thyroxine doses. If it doesn't, it is less than 10, you can taper off to half, or and slowly see if there is an elevation in TSH. So for especially the agenesis and ectopic thyroid, there is no point in retesting, because inevitably they need lifelong treatment. So case 3, we have a 4-day-old healthy neonate. So this is a 31 premature child with a birth weight of 1.4 kg. This is an AGA for 31 weeks, and we have a TSH of 5 units, T4 of low T4 and FT4. So clinical scenario, mostly it can be a premature child, so there must be a delayed response for TSH despite a low T4 and FT4. So a rescreen at 2 to 4 weeks is warranted for especially high risk in neonates like preterm, low birth weight, very low birth weight, that is less than 1 kg, and multiple births, because in twins there is a sharing of the cord blood, so there may be dilution, and in ill neonates because they have sick euthyroid syndrome. And the cause for low TSH, suppressed TSH in preterm may be a immature HPT axis, immature thyroid to synthesize the hormones, and a delayed TSH elevation by 3 weeks, which is seen by 3 weeks, and T3, T4 by 3 to 8 weeks. Thank you.
Thank you for your nice elaborate discussion. But just to stress the important point for screening, first is it has to be universal, as you said. But for universal, there should be facility for doing it. And remember, there are multiple childbirths, and many childbirths are there in the rural hospitals or even in the rural areas where there is no hospital. Sometimes India is a very heterogeneous country, so it should be easily transportable. That's the important point where the pilpric blood is very easy to carry, and there is transportation, and the loss of quality of the blood is not there. The Hilpric blood, that is the one of the reasons that Hilpric blood is taken, though the cord blood is maybe more accurate way of looking at it. But that is important, and we should be increasing more awareness among the periphery, especially where the universal screening is more challenging. We have one questions here, but before we go for the question, just to say one thing, as you said, the ectopic thyroid is a very dicey situation, and many a times you all know that there are obstruction in the throat, and there is a lingual thyroid is the most common presentation of ectopic thyroid, and many a times patient complains of this obstruction, and that ends up in surgery unless you go for a scan. So scan is definitely needed if you suspect ectopic thyroid, to exclude that location of the thyroid and it is not excised. So that is very important to be communicated to the all our friends, that this should be screened before going for a surgery in a cases of suspected ectopic thyroid. And look, now, as I said, there is a question to you. So when we start a thyroid replacement or congenital hypothyroidism, over serial follow-up, if the TSH is suppressed, even with the low doses of T4 supplementation, what is your approach in this situation?
So we tend to decrease the dosage by, in our institute, we tend to decrease by 12.5 microgram. That is half a tablet. We have a reduction in dose, or we try to, if it is difficult to break or we have issues with that, then alternate different doses we give. So the reduction is 12.5 is what we follow.
How frequent do you test them? Or this is not below 3 years, as you said. So not at the age of 3 years. So below 3 years. So what is the frequency of testing you look for, and what are the tests you ask for?
First time when we are testing FT4 at 2 weeks is the ideal response. That is our main target. Then TSH by 1 month we can do. Then serially, ideally we have to follow with FT4 or T4 with TSH. But if the affordability is an issue, we can go ahead with TSH. So here you can first initially it will be monthly for the first 2 months, then 2 monthly up to 6 months, then 6 months to 3 years you have 3 monthly testing. Then it can be 6 monthly testing. And when there is a change in dose, we have to repeat TSH at least 1 month of duration.
Thank you. So if there is no other questions, as because we are getting short of time, so we go to the second part of the session. So we have a quiz done by our uh, quiz master, Dr. Neeraj Sinha. I'm very happy to say that he is one of our students. So I'm congratulating him, and over to the quiz master, Dr. Neeraj Sinha, to conduct the quiz. Maybe. Dr. Neeraj, are you there?
Yes.
So
Thank you,
Dr.
sir.
Neeraj is currently affiliated with consultant endocrinologist in Paras HMRI Hospital in Patna. He has done MD Medicine, DM Endo. Areas of interest are diabetes mellitus, thyrotoxicosis, short stature, puberty, hirsutism, PCOS, sexual disorders, and others. And he he had been university toppers and gold medal in endocrinology, awarded as Inspiriting Endocrinologist Award in 2019 by Economic Times. So, congratulations, and over to you as a quiz master.
Thank you, sir.
Welcome, Dr. Neeraj. I think we probably just need to make the audience aware of, I think most people know the participation rules, so we can just leave this for a few seconds. I can read through for benefit of
Or
everyone.
we can just important rules to be talked
Yeah,
about. Maybe.
yeah.
Tell,
So I presume most people will know this, but the quiz is for 10 minutes.
no, maybe it is up to you, the quiz master, to discuss the salient important rules. Maybe.
Yeah,
Over to
Neeraj,
Neeraj.
you can, yeah, please go ahead, Neeraj. You can,
Yeah,
you
just the rules.
Yeah, just for the benefit of everyone.
Yeah. So the quiz is running for 10 minutes. There would be initially 2 dummy questions, and then the actual case or description of question by screen, sharing a PowerPoint file, and patient has to participate in the poll options. And all 10 questions will be available when the poll is launched, and answer for all the questions is to be submitted at once at the end of 10 minutes. To read the case or description, you can close the polls using the X button and again use the polls option to answer the respective questions. So initially there will be 2 dummy questions followed by actual quiz. So first of all, I would just like to know, would the questions be flowing from that end, or I have
Yes,
to
sir.
share?
Sir,
Okay.
dummy quiz is launch,
And then,
and then we'll
and
start with the actual quiz.
so the slides have to be shared by me or at your end?
Yes, sir. Yes, sir. You can share yours. You can share.
Oh, good. Thank you. Thank you. So the dummy question: in which city is Taj Mahal? And how many oceans are there? So these are single choice questions. So I think
So you can
we
share
have,
your screen. We start with the
yeah. So I think we know how to participate.
Now,
And
you
now,
show us the results. Maybe how do you show us? So that is one of the important way people understand how the results are shown.
sir, results will show at the end of the answers description.
Yeah, I'm talking about the dummy. So how it looks like.
Sir, dummy result we don't show usually. We show
Okay, go on with the quiz.
yeah.
so a very good evening to all my friends and seniors, my teachers. Let us brush up our knowledge on thyroid by this thyroid quiz. Should I read it?
Yes, sir. For each question, you just keep question for 10 seconds and you can move
Okay.
the slides.
Which of the following drugs can be responsible for lab report of normal TSH with increased FT4? Amiodarone, furosemide, prednisolone, low molecular weight heparin. Options 1 and 2, 3 and 4, 1 and 3, 1, 2 and 4. Question 1.
Sir, you can move your slides also side by side.
Okay.
Your sides are slid at
Yeah.
first slide.
So this is the first question. This is the second question. 26-year-old female suffering from Graves' disease is on treatment since 3 months and is presently on carbimazole 20 mg. Her FT3, FT4 and TSS done recently is within normal range and she is clinically euthyroid. Her pregnancy test has just come positive. What would be the best next step? Decrease carbimazole dose to 10 mg, shift her on PTU 50 mg TDS, check TSHR antibody level, or continue carbimazole at 20 mg dose. So I think
Just one question asked that whether these quizzes are visible to all the audience as well, not the people who are here as showing the questions and others.
Yes,
Is
sir.
it
The
audible?
quiz is visible to attendees and panelists both.
Both. Okay, thank you.
so. We can move to the next question. A person underwent lobectomy for thyroid 3, Bethesda 3, and biopsy suggests NIFTP. What would be next best step? Completion thyroidectomy, measurement of serum calcitonin, levothyroxine therapy to keep TSH less than 0.1, or levothyroxine therapy to keep serum TSH 0.5 to 2.0. So we can move to next question. There is a 49-year-old woman who comes with features of thyrotoxicosis for 3 months. Her thyroid gland is non-tender. TSH is less than 0.01. T3 is raised 385. FT4 is raised 2.4. Thyroglobulin is 76. There is poor uptake on thyroid scan. She is put on beta blockers, but she returns in 4 months with similar complaints and similar blood picture of TSH suppressed and increased T3 and T4. Next best step is inquire exogenous source of levothyroxine, measure ESR, start methimazole, or perform whole body radioiodine scan. So let us move to next question. Question number 5. A 32-year-old female with 16 weeks pregnancy is referred for thyrotoxicosis as evidenced by blood test. She has no nausea, vomiting, or vaginal bleed. Serum thyroglobulin is within normal range. Her other reports are as follows. TSH in pre-pregnancy level, 8 weeks, 12 weeks, 16 weeks, 0.51, 0.012, less than 0.01, less than 0.01. FT4, 0.9, 1.6, 1.98, 2.10. T3 at 12 weeks is 301 raised and T4 296. Beta ICG values are shown for 12 weeks and 16 weeks, which are in the normal range. So most likely etiology is Graves' disease, gestational thyrotoxicosis, subacute thyroiditis, and molar pregnancy. So coming on to next question. A 26-year-old female is on levothyroxine 88 microgram and liothyronine 10 microgram for control of hypothyroidism. She missed her period by 2 weeks and her pregnancy test has come positive. Her TSH 2 weeks back is normal 1.6. Next best step is continue same treatment, increase dose of both levothyroxine and liothyronine by 25%, increase levothyroxine dose to 125 microgram and continue liothyronine at same dose, or stop liothyronine and increase levothyroxine to 150 microgram. So patient on both LT4 and LT3, and she has been detected as pregnancy. What to do? Coming on to next question, question number 7. 40-year-old woman presents for follow-up of Graves' disease. She is receiving treatment for last 16 months and is on methimazole 5 mg since last 12 months. She is asymptomatic and is satisfied with current treatment approach. Her TSH is normal 1.05, FT4 1.17. TSHR antibody is 2.4, normal is less than 1.75. What is best next step? Continue methimazole at current dose, discontinue methimazole and monitor thyroid function, refer for radioactive iodine therapy, refer for thyroidectomy. Next question. Patient with thyroid storm crisis will have reduced levels of neutrophils, eosinophils, basophils, lymphocytes. Neutrophils, eosinophils, basophils, or lymphocytes in thyroid storm crisis are more likely to have reduced levels of neutrophil, eosinophil, basophil, or lymphocytes. Next question. 42-year-old man is noted to have TSH12 with normal FT4. He is asymptomatic. There is no goiter. Anti-TPO is negative. Ultrasound thyroid is normal. His one of the two children has similar test result. What is most likely cause? Hashimoto thyroiditis, excess selenium exposure, resistance to thyroid hormone, TSH resistance. Coming on to the next question, last question, 10th question. 46-year-old lady with history of rocks and Y surgery is on levothyroxine 400 microgram. Compliance is good. She takes medication empty stomach with no food or medication for 1 hour. Her FT4 is 0.6 and TSH is 18. The screen for celiac disease is negative. Mild pedal edema is present. What is next best step? Change to liothyronine. Increase levothyroxine dosage to 500 microgram. Change to once weekly levothyroxine 3 milligram, or switch brands of levothyroxine. So patient with rocks and Y surgery already on levothyroxine 400 microgram, yet TSH is high, FT4 is low. What to do? Change to liothyronine, increase levothyroxine dosage, change to once weekly levothyroxine 3 mg, or switch brands of levothyroxine.
How long should you wait?
I think it's done now, isn't it? You've wait. Each question was for 15 seconds.
Yes, so the quiz is done. You can move to the second presentation.
But should we present the result now or later?
No, that will be in the end. Yeah. So you can proceed with the next presentation of Sena, or can.
Oh, sure. So we have our second case, an equally interesting case by Dr. T.R. Lakshmi. She is actually she is working as senior resident Department of Endocrinology in SCPJ Lucknow. This case is another aspect of the young children with thyroid disease. That is, we discussed the congenital hypothyroidism. Now we are going to discuss the other spectrum of the disease, that is hyperthyroidism, or the commonly presentation as Graves' disease. Though the Graves' disease is not very common in childhood, but the presentation is sometimes different and not a classical presentation of Graves' disease as we see in the adult population. So it should be have a good clinical eye to look for it and how to look for them and how to treat them accordingly with the different drugs. So with this, we are going to discuss with these things by Dr. T.R. Lakshmi. Over to Dr. T.R. Lakshmi to discuss the point.
Good evening, respected consultants and my dear colleagues. So for the next case for today's evening is that of a case of Graves' disease in childhood. So here we had a 12-year-old girl who was a student of class 7 from UP who presented with history of neck swelling and protrusion of eyes for 9 months, tremors and loss of weight for 5 months. So this neck swelling was in the center of the neck, not associated with any pain or rapid change in size. It was only gradually noticed. She also noticed that she had protrusion of eyes for the previous 9 months, which was gradually progressive, involving both eyes without any associated redness, pain, double vision, blurring of vision, grittiness, or lid swelling. And she also had loss of weight that was about 5 kilograms in the previous 5 months. This was despite a preserved appetite. She did not have any excessive sweating or heat intolerance, no history of increased frequency of bowel movements. She did not have any fever or sore throat, no history of palpitations. She did not have any recent worsening of scholastic performance, no history of difficulty in breathing, a difficulty in swallowing or change in voice. She didn't have any swelling of legs, no hyperpigmentation, abdominal pain, diarrhea, no history of any joint pain or skin diseases such as vitiligo. In the past, for the same complaints, when she had presented, she was evaluated elsewhere and started on antithyroid drugs in 2022. And she was started at about 0.34 milligram per kg. Later, it was increased, which I'll be explaining later. And she didn't have any, she had not attained menarche yet. And in the family, she did not have anyone else who had a thyroidal illness or other autoimmune diseases. On examination, she had a height of 138, that was between 75th to 97th centile, and a weight of 43 kilograms, that was 10th centile, and a BMI of 22.6. She had tachycardia, a blood pressure of 120/60, which had a wide pulse pressure. In general examination, she had fine tremors, warm peripheries, no dermopathy, onycholysis, no skin manifestations such as hyperpigmentation or vitiligo was noted. On the examination of thyroid, it was a diffusely enlarged, slightly asymmetric, with a smooth surface and no separate nodules. It was moving with deglutition. The gland had no prominent veins on the surface. It was non-tender, soft in consistency, about 5.5 on the right side and 5.5 on the right side and 4.5 on the left side. There was no thrill palpable. Lower border was palpable, and there was no bruit on auscultation. On the eye examination, she had lid retraction, the maximum of 2 millimeter in the lower eyelid, and there was proptosis about 18 millimeter measured on Hertel's exophthalmometer. When compared to the population mean, it was 15 and 3 millimeter above the population cutoff for the corresponding age group. Her clinical activity score was 0.7 and she did not have any of the features of clinical activity such as redness of the lids, conjunctiva, no chemosis or lid swelling or caricular swelling. She did not have any pain at rest or on movements. She did not have diplopia or restriction of eye movements as well. There was no lid lag or lag of thalamus. The pupils were bilaterally 3 millimeter and reactive to light. Her visual acuity, color vision, and fundus examination were within normal limits. Though the picture quality is not very good, we can see a diffusely enlarged gland and lid retraction that is noted without any redness or swelling. On systemic examination, she did not have any features of congestive heart failure, no organomegaly, and there was no neurological deficit or brisk reflexes. So with this, we considered a diagnosis of thyrotoxicosis. And since Graves' disease is the most common cause of thyrotoxicosis in childhood, and considering the duration as well as the orbitopathy, it was more suggestive of Graves' disease. And the orbitopathy was moderate to severe since she had more than 2 millimeter more of proptosis compared to the population mean. And she did not have any dermopathy or acropathy. Can I please proceed to the investigations?
Yeah, you can, but before that, can you just differentiate how to look for the other excluding points which can look like thyrotoxicosis in a child? So that is very important learning for us. So what are the things we need to exclude as a history? So other drugs, other things can be a thing, maybe. So this is important. Yeah. So
Yes.
go on.
So the other things that we should consider in this child would be, of course, when a child presents, we should look for other subtle features such as hyperactivity or worsening of scholastic performance. And when there could be an accelerated growth or accelerated bone age, these should be looked for. And in examination, more important thing is to look for any separate nodule that stands out. Of course, skin manifestations for in the form of capillary-macules, Truloto-McCune-Albright syndrome should be looked for. And pubertal status, if at all any acceleration is, if at all it's present, that should be considered. And if any separate nodule is noted, then again we should consider the possibility of toxic adenoma. Other than that, children, most important thing would be to rule out McCune-Albright syndrome, considering the age group. Affectitious would be very rare, and that would be the significant thing, sir.
Thank you. Go on with your reports, but we require definitely a bone age, maybe for this duration of the illness, maybe.
Okay,
Go
sir.
on.
So when we came, though we didn't have her initial report, from what was available, I could tabulate this, and we can see that from the June 2022, the reports were available. The rest were not accessible to us. So there was a suppressed TSH along with an elevated T3 and T4 hormones, at which stage she was started on a high dose of carbimazole, 1.16 milligram per kg. Following that, she immediately had features like biochemical features of hypothyroidism. From there, the treating physician had tried to decrease the dose. Then it kept fluctuating, and it again went to our thyrotoxic range in November 2022. And though the reports are missing for the intervening period, in June 2023, we can again see that it has again risen in both T3 and T4. TSH is again suppressed. And when she presented to us, the levels were T3 of 5.23 nanogram per ml, T4 of 15.5 microgram per deciliter, and TSH was suppressed. At this point, she was on 20 milligrams. That's about 0.46 milligram per kg. She also had imaging with her, which showed bulky and heterogeneous thyroid glands, and the right measuring 6.3 into 3 centimeter, and left measuring 5.2 into 2.2 centimeter with altered echo texture. There was increased vascularity noted, which was evident in the picture. We can see that there are patchy areas of increased vascularity, noting which signifies the increased blood flow and the arteriovenous shunts, which is often termed thyroid inferno, and a peak systolic velocity of more than 60 centimeter per second. Often we take a cutoff of 40 in the inferior thyroid artery. That is again significant. She also had an MRI orbit that was done, but did not show any involvement of extraocular muscles or any optic nerve involvement. So we repeated the thyroid function test that showed a suppressed TSH and a T3 that was 5.25 nanomoles per liter. In our lab, the TRAB was 39.56, which is above the cutoff of 1.75. Since we didn't have her baseline TLC and liver functions, we did that to rule out a neutropenia and a liver dysfunction, which is to be done in any child before starting the therapy, since the drug itself, since the primary disease itself can cause both liver dysfunction and agranulocytosis. So we continued her on carbimazole of 40.
Just sorry to disturb you, but your patient was already on antithyroid drugs when it reached you. So how do you decide that it is the beginning of the treatment?
No, this is not the beginning of the treatment, sir.
What I'm saying, so it is not the beginning. So you said it has to be screened before the beginning. But
ideally, yes. Ideally, yes.
It's not the beginning of the case.
Yes, it is not. Ideally, it should be done starting, since the primary disease itself can cause those manifestations.
Yeah, go on.
Yes. So we continued her on carbimazole, and we also, since she had tachycardia and sympathetic overactivity, we also gave her beta blockers. And when she came back to us about 4 weeks later, she had gained about 1.5 kilograms weight, and she also had no tremors. Her heart rate had become 86 per minute. Her clinical activity score was 0/7, that is, she did not have any worsening. Her proptosis had slightly reduced, and we can see that the T3 was still slightly elevated, though the TSH was in suppressed range. And this is to just show that the T3 and T4 are to be closely followed in the first 6 months, because those are the deciding factors for the drug dosage, and not TSH, because it can remain persistently suppressed. So at this point, since the patient has been on high dose of thionamides, the possibility of secondary therapy was considered and also explained to the parents. And the plan was made after considering the options that to continue medical therapy, and further, if at all there is any worsening or further increase in dosage requirement, to consider second-line therapy, which would most probably surgery in this case. So can I go ahead with a few slides of discussion, or is there a point to be? Okay, thank you.
We'll discuss it.
Yes. So in children, when we consider the drug therapies, the possible options are methimazole and carbimazole. Because of the risk for hepatic necrosis, propylthiouracil is not used. We have two dosage regimens, that is, either we can do a dose titration approach or a block and replacement approach. The dose titration, block and replacement, biochemically, though they are similar, the block and replacement has been slightly found to have increased adverse effects. when we try the dose titration method, the starting dose is less than the block and replace regimen. So we start at 0.15 to 0.3 milligram per kg of methimazole or 0.25 to 0.5 milligram per kg of carbimazole. Then, based on the T3 and T4 levels, the dose can be reduced by 25 to 50% if it is in the euthyroid stage, and if it is in the hypothyroid stage, we decrease it by 50%. That doesn't mean this is the maximum dose that can be given. We can give larger doses depending on the severity of the disease, and up to 1.3 milligram per kg of carbimazole and 1 milligram per kg of methimazole can be given as the antithyroid drugs. But at this stage, one should also always consider the backup of second-line therapies because of the risk of adverse effects. When we look at block and replace approach, the dose of starting dose itself is slightly higher compared to the dose titration. And here we try to suppress the endogenous thyroid hormone production. And as the thyroid level, hormone levels fall into the normal range, we replace it with levothyroxine without letting it fall into the hypothyroid range. In our institute, we are following dose titration approach. The side effects are minor side effects are seen in 10 to 15%. This can be an antichoria or a pruritic rash, but the major ones such as agranulocytosis or severe leukopenia are very rare. But there should be a standing instruction to stop the drug if there is a case of fever or sore throat, and to do an immediate CBC and report back to us when we suspect such things. So that standing instruction should be given to all patients who are being put on thionamides. So the remission rate is slightly less compared to the adults, and overall remission rate is after 2 years of therapy is about 20 to 30% only. As the duration of therapy increases, the remission also increases. The recommendation by the European Thyroid Association is to at least treat for 3 years. And if we think that the patient would require longer treatment for remission, we can continue up to even 5 years or even longer. Different studies have looked at the different factors that improve the likelihood of remission. And these are older age, female gender, Caucasian ethnicity, smaller goiter size, mild biochemical derangement at diagnosis, lower TRAB levels, no history of other autoimmune conditions, and a shorter duration of ATD treatment. So there was a recent publication in 2023 that again looked at these factors, and they have proposed that the goiter size of less than 3.5 centimeter, TRAB less than 10, and absence of Graves' ophthalmopathy, and a lower dose of methimazole requirement at 1 year are predictive of remission. There have been other studies as well. This has been about 260 patients were included in this study. And talking about one more study that was done slightly earlier and was published in 2008 in JCM. Here they've looked at about 154 patients and tried to make a scoring system to predict the relapse rates. The parameters they've looked at are again ethnicity, age, FT4 concentration, and TRAB levels, and the duration of ATD treatment. Using these scores, they have classified the patients into different strata, into different groups, that is 0 to 3 score, 4 to 7, and more than 8. With this, they've tried to predict the scores, and observed scores have been compared. So we can see that there was a good correlation between both of these parameters. So then again, this has been another attempt at predicting the relapse rate. So we can see that as the scores increase, the relapse rate is much high. Overall, when we look at the management algorithm, finally, after diagnosing, we start the patient on methimazole or carbimazole, and we try to give a good duration of therapy at about 3 years, at least around 3 years. And then when we find the patient is requiring only a very low dose, such as 2.5 to 5 milligram of anti-thyroid drugs only, and we can see, and if we see that the TSH is in the normal range, we can see that the patient is likely to go into remission, or may even go into gland failure if it is going to hypothyroid range. So at this point, we can have a trial of decreasing or stopping the antithyroid drugs and look for relapse. So when we look for relapse in the early period, we have to follow up at least at 4 weekly intervals for the initial 6 months. Then we can make it 3 monthly and then 6 monthly. Finally, we have to follow up at least annually for a prolonged period. And also, if there is a relapse, either we can go back to antithyroid drugs or consider second-line therapies. So when the second-line therapies, other indications for starting second-line therapies would be when there is a large goiter that is causing compressive symptoms, when there is very poor compliance that is refractory, also when there are refractory or life-threatening side effects, and if the patient, being a young child with learning disabilities or a situation like that, is not able to express the side effects. In all these situations, we should consider second-line therapies. So the second-line therapies that are available to us would be surgery, the total thyroidectomy, and radioiodine ablation. Surgery would be preferred in children less than 5 years, as their gland is much sensitive to the radioactive iodine, and they have a slightly increased risk of malignancy if given at such a low age. Also, when we refer for surgery, we should refer them to a center with a good volume surgery that is being done to decrease the rate of complications such as recurrent laryngeal nerve injury as well as hypothyroidism. When we look at radioiodine ablation, that is preferred for age more than 10 years and post-pubertal. Between 5 to 10 years, if there is if the surgery is not acceptable or surgery is having other contraindication, then we try and give radioiodine ablation at a lower dose. The aim of both these modalities is to produce hypothyroidism and to easily keep treating with thyroxine for a lifelong supplementation and to monitor them with FT4 levels. So these are the modalities that are available to us. I do not have any further slides for discussion. Is there anything else anyone would like to
I have
ask?
just 2 points to talk about. Just for your own presentation, there is a waxing and waning levels of thyroid for last 1 year before it presented to you. So what
Yes,
is
sir.
your take on it? Because there have been trying of titrating the dose, but still the hypothyroid and hypothyroid was relapsing. And so what is your point on it? What do you want to say?
Yes, sir. So in this, I think the dose titration maybe if the treating physician maybe tries to decrease it or had not started such a high dose, that would not have occurred in such an unstable manner. So one point to take care is the dose titration and to go like really slow about it by decreasing only little by little in the beginning and to not give like such a high dose maybe in the initial stage. Like the starting dose that patient would have been received must have been a little high, I guess, based on what is seen here. And the second thing is, if there is such a very unstable hypothyroid, difficult to control disease, always we can consider second line therapies. And this patient as such is having a high risk profile when we look at all the parameters that we just discussed for relapse, like high TRAb levels, orbitopathy, and difficult to control hypothyroidism and greater FT4 levels. So this patient would be actually a good candidate if it's not getting controlled with medical therapy to go for second line therapy. In this case, possibly surgery or radioactive iodine. But in case of radioactive iodine, we should be always aware of the fact that the orbitopathy can worsen. Since it's not clinically active, she doesn't mandate the receiving steroids. But if there are other risk factors, when we subject a patient to radioactive therapy, such as increased TRAb levels, smoke exposure, then we should give adjuvant steroids to decrease the risk of thyroid storm.
Thank you. And then maybe we have another important point. Say, if this patient, as a hypothesis, have a altered liver function test with the treatment with the levothyroxine or this carbimazole or methimazole, whichever you give. So what is your take on that? So what do you manage then accordingly? So if the patient LFT becomes 3 times of the upper limit of normal, so what you do, and 5 times of the upper limit of normal, what you do?
More than 3 times upper limit of normal, as per the ETA guidelines, it's mandated to stop the therapy. So at this point, we will have no choice but to withdraw the antithyroid drugs and start beta blockers temporarily. And this patient should be subjected to a second line therapy soon. So at this point, when the patient is being subjected to second line therapy, if you're choosing a surgery, then we should give other measures for controlling the thyroid hormone release, such as iodine solutions and adjuvant steroids. So, and again, when it is going to the when it is going for the therapy, this should be done at least 2 weeks prior, so that thyroid storm is avoided, and the appropriate time when the patient's thyroid function levels are like most acceptable, the patient should immediately go undergo surgery.
So, do you think there is any other role of converting from one to other, say stopping the carbimazole, starting the PTU, or not in the children at the age of 5 years, 10 years, but in the 12, 15 years, as you said? So, do you think that it can be tried?
So, but PTO also is known to cause hepatic dysfunction,
Yeah.
though the type of dysfunction differs. In the other
Different.
two, it
So,
would be polystotic. This would be a hepatocellular type.
yeah, that is a different way that what I'm asking. So, what is your take on it? So, what do you think you should do? Because sometimes the patient do not have the time, and patient is seriously toxic. So, you have to do something that's a bit blocker, sometimes does not work. So, what is your
From the little experience we have seen here, the patients, when we had such patients who had liver function, which we could not differentiate whether it was drug related or sometimes thyroid storms related, we have started them on cholestyramine also at some point, and other than beta blockers, the immediate measure was to make them undergo the second line therapy. That's what we have done. Though we have not had the circumstance in children, we have had this in adults.
Okay, thank you. So I have, let's see, we have few questions. So one question to how to follow a hyperthyroid patients. Probably this is the relation to the pediatric age group. So only FT3, FT4 or with TSH also. What importance to TSH in the patients on treatment with antithyroid medication? You have discussed it, but give an action.
Yes. We should follow all the three parameters. Especially the importance is given in the first 4 to 6 months for FT3 and FT4 levels. So this is used for titration, and later after 6 months, all the three should be followed. It's just to the clarification is that TSH will be could be persistently suppressed for a prolonged period. So we should look for the active hormone levels. And FT3 is often more difficult to control compared to FT4. So that point should be taken care. And if a patient is having FT4 that is normal and TSH that is suppressed, you might not we would be surprised that it's because of the FT3 that is often suppressed. And also we should check for complaints in these scenarios. So all the three should be followed. That would be the answer. And TSH, if at all it is going into elevated, that is, it should be maintained below the upper level of normal. Like if it's 4 is the cutoff, it should be below that. If it is going beyond that, the idea would be to decrease by 50%. And when we are using dose titration regimen, so we reduce by 50% and try to prolong the therapy as much as possible, at least for 3 years.
Just last question, maybe that you have discussed the guideline nicely. What age you consider the radioiodine compared to the others, different ages. But at your place at ACPJ, people have asked that what at your age, at what age in your place ACPJ consider radioiodine therapy in the childhood groups. So that is the specific question as a maybe the institution-based guideline of your place.
At this point, we have not had at this point any patient who had required referral to such a young age. So I would say that Preeti ma'am
Can
could
I answer
probably
that
weigh
for
in with her
Lakshmi?
experience.
Yeah,
Hello, ma'am?
anyone in the panel?
10 years. 10 years. Usually we consider, we have given radioiodine 10 years and above. We have not given it. I think a couple of children have received it at the age of 7 and 8, but they were sort of extreme cases. But usually 10 and above we give, not under that. We have not given it.
So thank you. And we had a nice discussion on both the aspects of the thyroid disease. And we have discussed the pediatric age group of hypothyroidism as well as hyperthyroidism. We understood a lot of things. Hopefully, the panelists has contributed and a lot, and the people who have participated, we understood and cleared our thoughts regarding the aspects of childhood management, because we do not see this kind of cases commonly as pediatric graves or these adolescent graves. So, with this, I complete this part of the session, and we are waiting for the results of the quiz. Maybe see if we can have it, and then we go to the paper for the conclusion and other points.
Thank you, Dr. Sinha. Thank you, Dr. Sinha. Asmita, have you got the results ready?
So this is very important to have the results of the quiz. Very interesting.
I think Dr. Neeraj can.
Yeah, Dr. Neeraj, are you there?
Present the winners. And in fact, sorry, you have to actually perhaps very quickly discuss the answers and your explanation of the answers. If you can do that first, and then we will have the winners by the end of it. Yeah.
Yeah,
please.
by the time the results are out, let us discuss the answers.
Please.
Just in brief, because we are getting late.
Yeah.
Make it in the PowerPoint mode.
Yeah, yes, please.
Hopefully it is either there or down.
Yes, just 1 minute, sir.
Down and right. There is a point.
Yes.
Or there is a slideshow in the top. From the
Yes.
home, go fourth, fifth, sixth one, third, fourth, fifth one. From the home, you go right. This is insert, then design, then transition, then animation, then slideshow. Go there.
Yes.
Yeah. From here, you go. Second is insert. Third is design. From there, fifth is slideshow. In the up. After home, from home, which is highlighted. The home, which is highlighted with orange. From there, you go right.
Yes.
Same row. In the same row of the home.
Sir, on menu bar, the sixth icon is slideshow. Can you click on that?
Yes.
Or you
No,
can
that,
just
not that
Understand.
menu.
This
yeah,
is-
yeah, yeah.
Yeah, yeah.
Do,
Click on the form
yeah,
beginning.
do that. Do that. Click that.
Yeah. Just 1 minute.
Button is disabled.
Yeah.
Before 82%, can you at the down of your screen, before 82%, there is icon of a square, and before 82%, yeah, click on that.
Yeah. 1 minute.
Yeah, click.
Click
No,
that.
it is. No, it is actually
Click.
not. Oh,
Why?
just
So
just one.
I'll share your.
Okay, you discuss on this mode only. Go on. Go
Discuss
on
in
with
this only. Let us discuss.
yeah.
So let
Go on.
us go
Sir, can
to
I show your slides?
yeah. Yeah.
Sir,
Let
can
us
I show your slides?
yeah. Please.
Yeah, discuss the points. Right. Now we are visible. Go back to the first question.
Yeah, let us see at the first question. Very often we are puzzled with values of normal TSH and increased FT4. Many a times they are drug interactions. And among these, amiodarone, furosemide, prednisolone, and heparin. Amiodarone, furosemide, and heparin can produce such result. Amiodarone inhibits T4 to T3 conversions. So FT4 can be high with normal or high normal TSH. Furosemide displaces T4 from binding sites, and also heparin, that they induce lipoprotein lipase and they displace T4 from thyroid binding globulins. Glucocorticoids actually decrease TSH, hence the answer would be 1, 2, and 4. And in this case, 26-year-old female is suffering from Graves' disease and is clinically and biochemically euthyroid, and her pregnancy test has just come positive. So this at the time of organogenesis, it raises the possibility that she may not require anti-thyroid drugs, and that would be beneficial for the fetus. So here, when she's biochemically and clinically euthyroid, we can check the TSHR antibody to confirm that her disease is not very active. And if TSHR antibody is negative, then we have the option to stop carbimazole and keep on checking thyroid profiles in 1 week or 2 week period time. Alternatively, also, we could have reduced the dose, but this would be a better approach. A person has underwent lobectomy. The biopsy suggests non-invasive follicular tumor with papillary-like picture, and this is NIFT. NIFT is generally considered very low risk. The risk for tumor recurrence is extremely low. Lobectomy provides sufficient treatment. We do not need completion thyroidectomy. Serum calcitonin is not required in follicular neoplasm, and therefore the aggressive approach of keeping TSH less than 0.1 is not required. So keeping TSH in the range of 0.5 to 2 would be the next best step in this case of NIFTP. Next. Here, lady is suffering from thyrotoxicosis. She is put on beta blockers. She comes again after 4 months. So a long period, more than 6 months, she is in thyrotoxicosis, and therefore chances of thyroiditis being is less, and also therefore measuring ESR would be low. Would not prove useful. Also, there is no mention of neck pain. Exogenous source of levothyroxine is not suggested as thyroglobulin is high. And starting methimazole would be a good option, but that will not find the cause. Many a times when the radioiodine uptake is low at thyroid and thyrotoxicosis is persistent, then we have to look for extrathyroidal source of thyrotoxicosis as like struma ovary, and therefore we should perform whole body radioiodine scan. Next. She is a lady with 16 weeks pregnancy. From the pre-pregnancy to 8 weeks to 12 weeks to 16 weeks, we find that thyrotoxicosis is persistent. Most commonly, we come across gestational thyrotoxicosis, but gestational thyrotoxicosis is accompanied with rise in HCG and is almost always associated with nausea and vomiting. So if nausea, vomiting is not associated, and even when HCG has started to fall after 12 weeks, as we see normally as HCG is falling, yet the thyrotoxicosis is not resolving. So in this case, gestational thyrotoxicosis is less likely. Molar pregnancy is generally associated with vaginal bleed and would be a different picture. Thyroiditis can be possibility, but here the duration of thyrotoxicosis is going more than 3 months. It is persisting till 16 weeks. And also there is no mention of neck pain, tender fever or neck pain. And therefore, the most likely etiology here would be Graves' disease. Next. Here, patient, this is important because many of our patients would now be on liothyronine. So patient on levothyroxine 88 and liothyronine 10 mcg. With regard, whereas we are using in normal population, but in pregnancy, what happens in early pregnancy, the fetus is totally dependent on maternal thyroid hormones, and the transplacental transfer of maternal thyroid hormone is primarily of T4 and not significant for T3. So therefore, if we continue by increasing the dose of both, actually normalizing maternal TSH on combination can lead to fetal hypothyroxemia. And therefore, liothyronine, which is metabolically 3 times more potent than levothyroxine, so 10 mcg of lio would be equal to 30 mcg of levo. And as in pregnancy, we generally increase the dose by about 25 to 30%. So 88 plus 30 multiplied with 125 to 130% will give the dose of levothyroxine to 150 mcg. So liothyronine cannot be continued in the pregnancy as the transplacental transfer is very less, and this will lead to fetal hypothyroxemia. So we should convert into levothyroxine. This is 40-year-old woman who presents for Graves' disease, and she's for last 16 months, she's on methimazole 5 mg since last 12 months. She's asymptomatic, satisfied with current treatment. TSH FT4 is normal. TSHR antibodies mildly raised. So here, traditionally, when after 18 to 24 months, if we are not able to achieve the remission, then we go for radioiodine or surgery. But this lady has completed 16 months, and also recent studies have shown that long-term low-dose methimazole therapy is safe and can be continued for long. Some studies suggest that quality of life may be affected with radioiodine treatment. Many a patient would not like that radioiodine treatment may not be preferred. So a lady who is asymptomatic at 5 mg dose and her TSHR antibody is positive, we can continue the methimazole at the current dose. Next. Patient with thyroid storm crisis will have reduced level of neutrophils. We know that thyrotoxicosis itself is a cause of neutropenia. Many a times in thyroid storm, this becomes a tricky situation. When a person comes with low neutrophil count, should we institute therapy or not? In mild to moderate neutropenia, we can, of course, start the therapy. And also, we will have to considering the mortality of thyroid storm, we will have to cautiously perhaps do the anti-thyroid treatment in the thyroid storm, but at least in mild to moderate neutropenia, we can use anti-thyroid drug with confidence even in thyroid storm. So thyroid storm crisis will have reduced levels of neutrophils. Next. So this person, TSH12, normal FT4. This is a common finding in most of the patient. This looks like subclinical hypothyroid, and subclinical hypothyroid is generally caused by Hashimoto thyroiditis. But in this patient, there is no goiter, anti-TPO is negative, ultrasound thyroid is normal. Therefore, there is less chance of Hashimoto thyroiditis. With regard to thyroid hormone resistance, that leads to high FT4, which is not seen in this case. Selenium exposure does not cause high TSH. It has been seen lately that many patients, we find this case that there is actually inactivating mutation in TSH receptors. And this is more common than once realized. And therefore, there is asymptomatic in most cases elevation of TSH because there is resistance in the TSH receptor. And this leads to increased TSH and normal FT4. So the correct answer here would be also his 2 children is having similar test result. This is generally autosomal dominant. So the correct answer here would be TSH resistance. Next. This is patient after ROX and Y surgery on levothyroxine 400 after ensuring compliance. Patient is also having mild pedal edema. Patient is actually experiencing malabsorption. So changing to liothyronine will not help because the main issue is malabsorption. Changing to once weekly levothyroxine will have the same problem, and switching brands will have the same problem. So when there is malabsorption, the most correct approach would be increasing the levothyroxine. This malabsorption can occur because ROX and Y surgery involves the absorption area distal small intestine, and therefore patients are liable for malabsorption. So we will increase the dose of levothyroxine here.
So thank you, Neeraj. I hope by the time these results are ready, so we are excited to learn the result.
Okay, Dr. Neeraj, you can announce the names.
So congratulations, Dr. Renu Sehgal and Dr. Kulayappa Pulavari. They are the quiz winner of today. Oh,
yeah, that is from yesterday, and this is
that was from yesterday, and for today, Dr. Vibhu Ranjan Khare, Dr. Archana K, and Dr. Shubhankar Chatterjee. Congratulations.
Okay, so thank you so much. So I think it's a proud privilege to thank you all. First, the chairperson, Dr. Preeti, who has facilitated this this session by the cases, by her team presenting the cases. Thank you, Dr. Preeti. And a big thanks to Dr. Anirban Sinha for his wonderful moderation and bringing out 2 cases, one a very common scenario, one not so very common scenarios, and the discussions were very, very clinically oriented and very useful. Thank you so much, Dr. Sinha.
Thank you.
And a big thanks again to the two senior residents who presented today. Dr. Archana K, it looks as if she also won the quiz, so she's she's got a double she needs double congratulations today. And Dr. Archana and Dr. T.R. Lakshmi, wonderful case presentations, very, very clear and concise. So thank you so much once again from the ITS team. And
Thank you, sir.
Thank you. And most importantly, Dr. Neeraj Sinha, who has taken so much effort in the quiz. I think the highlight of the quiz was that all the questions were very clinically orientated. And I'm sure that is a very, very useful quiz session. I'm sure all of us would have gained quite a bit from those cases and from those quizzes. I would like to thank all the audiences for staying, even although we have got a little bit late, for staying with us. And the IT team, especially Asmita, for supporting us. They've been a great support over the last year and a half
Thank you, sir.
for this wonderful sessions. So thank you so much. Thank you, everyone. And until we meet next time, have a good evening and rest of the month. Happy and Merry Christmas as well. Good night.
Thank you, Arun.
Good
Thank
night,
you.
all.
Thank you. Good night.